everyone. So for anyone who hasn't met me yet, one of the PGY1s. So this lecture is part of the visual diagnosis series. So we won't be talking much about management, but more so focusing on recognizing and accurately describing fractures, specifically upper extremity. So I have no conflicts of interest, no financial disclosures. I'm but a lowly intern. So objectives, provide a systematic approach to reading orthopedic radiographs, review terminology to probably describe these fractures that we see. And then 3 is just to go over 5 cases to cement our approach and terminology. So the systematic approach, as with many things in medicine, especially when reading images, it's important to have a systematic approach so we don't miss anything, especially those subtle findings. The mnemonic that most people use when approaching fractures is the A, B, C, and S. So A is alterations to the skeletal contour or alignment between bones. B is bones, so this is like what we're always looking for, the visualization of those fracture lines. As we all know, they usually appear as radiolucent breaks in the cortex or trabecula, but if fractures are impacted or there are multiple pieces overlying one another, they may appear radiopaque, so just something to keep in mind. 3, cartilage, so looking at those joint spaces and seeing that there's normal width and uniform spacing. And then 4 is soft tissue, so looking at the surrounding soft tissue to see if there's any abnormal position or obliteration of fat planes between muscle layers due to edema or hemorrhage that can be cueing you into a nearby fracture. So now that we have our systematic approach, going into terminology. So step 1 is location. Where is the fracture located? Is it in the diaphysis, broken into proximal, medial, and distal? Is it in the metaphysis, which is the next section of a long bone, or is it in the epiphysis? So there is a debate in the orthopedic community that once you reach adulthood and you lose the growth plate, they consider everything below just metaphysis and there's no more epiphysis. But since there's debate, describe it as you like. So once you've found the location of your fracture, identify what type of fracture is it. So is it a complete fracture, meaning the fracture has gone through the entire diameter of the bone? And if it is complete, ask yourself, is it transverse, a nice clean cut across? Is it oblique at an angle? Is it a spiral, looks like a corkscrew? Is it comminuted, more than 2 pieces broken, or is it segmental? So there's a whole section that's cut off from the rest of the bone. If it's incomplete, ask yourself if it's bowing, a green stick, so just a little nick into the bone, or is it torus, also known as a buccal fracture. And then just a little nerd point, torus is coming from the Greek term for the end of the Greek column, which is a torus, so it looks like that little buckle that we see on imaging. Also ask yourself if this is a pediatric patient, we have to consider our Salter Harris if this is in the growth plate. I won't go through all the different types since we all have studied that a bunch. And then the last 4, just special considerations are your avulsion and stress fractures, impaction and compression. So how I like to remember the difference between impaction and compression is just, compression is like our vertebral compression fractures where the bone is just flattening and grinding against itself. And then impaction is when you have enough force, axial load, where it causes a piece of bone to be driven into the other piece. So once we have location, the type of fracture, think about displacement. So this is getting more into the weeds of things, and usually radiologists will just use displacement to say whether the fracture is or isn't aligned when compared to the proximal aspect of that bone, but it actually has 3 separate aspects to it. So one is translation, which is when you're looking at that distal aspect of the bone, how off center is it when compared to the proximal aspect? And they talk about it in percentages. And then second is angulation. So meaning how much of an angle has that distal portion of the bone gone off when compared to the proximal aspect. In the upper extremity, you can talk about it as, has it gone towards the radius, the ulna, or has it gone dorsally or ventrally? And then in the lower extremity, like the picture shows, it can be either be a valgus or varus angulation or an anterior or posterior angulation. And lastly is rotation. Has it rotated internally or externally? So now that we know our terminology and our systematic approach, let's just go through some cases. So case one, 24-year-old man was hit with a baseball bat over his left forearm during an altercation he had with some Yankees fans. He admits that, to having continually cursed them out and saying they ain't nothing compared to the Mets. So you get some radiographs. These are the two images you get. So can anyone read these images for me going through our systematic approach? What are the changes in alignment, if any? What fracture do you see? Any joint space changes or soft tissue swelling? We can start with like obvious fractures that you see. Big one in the middle. Yeah. Okay. Yep. Mm-hmm. Just a little bit, yeah. Yeah. Yeah, no, that's good. So this, looking through it, is you see that there's a large transverse or oblique fracture through the ulna, and that the distal portion is dorsally or ventrally displaced. And then one subtle finding, maybe you saw or not, is the radial head at the top over here has been pushed up into out of its articulation. Does anyone know the type of fracture this is? With the, yeah, Monteggia fracture. So that's when you get the ulnar mid fracture that always usually happens in the proximal or medial shaft, and then you get that radial head dislocation. Does anyone know what it would be called if there was no radial head dislocation and you just had the ulnar fracture? Yeah, sweet. So case two, a rambunctious and admittedly clumsy 4-year-old Brazilian boy falls on outstretched hands, tripping over himself while his grandpa chased after him, attempting to get him to take a family picture during vacation. So this is the radiograph. Anyone want to get a shot at what's going on here? We don't have to go in order of the ABCs, just shout out what you see. Any changes to like any obvious fractures? Yeah, exactly. So what MJ was saying, for everyone at home, pointing out the posterior fat pad, and then there is a fracture in the humerus, the distal aspect of the humerus. Anyone, what's the name of the fracture? Sweet. Okay, so yeah, so I sustained a supracondylar fracture when I was little. Not only is the fracture the obvious sign, sometimes it can be really subtle and hard to see. One of the more specific and sensitive signs is actually that change of the anterior humeral line. So normally it will go straight through down and transect the middle 1/3 of the capitellum. But if that's off alignment, like you see on this picture closest to me, that might be a sign that there is a subcondylar fracture, because although there is fat pad signs posterior and anterior, that can also be present on your lateral condyle fractures. So they're not just a dead giveaway to a supracondylar fracture. And another point is that the radiocapitellar line will always stay intact. It will transect exactly in the middle of the capitellum in your supracondylar fractures, but in a lateral condyle fracture, that alignment will be gone and obliterated. So just a point to make. Case three, 84-year-old woman presents with wrist pain after falling on her outstretched arm. She was dancing salsa, grooving to the music in the town square when she lost her balance. You get radiographs. What do you guys see? Yep, distal radius. Anything else? Yep. So as people point out in the lecture hall, there's a distal radius fracture, and then the ulna is out of alignment. Anyone know what this presentation is? There's a distinct name for it. Yeah, the Galeazzi fracture. So Galeazzi is a complete transverse or oblique fracture of the distal 1/3 of the radius. And this can be either dorsally or ventrally displaced. And in our case, it looks like there is ventral displacement, but it can go either way with an associated dislocation of the distal ulna. Okay. And then case 4, a 140-year-old dwarf presents to a Hobbit Run ED with wrist pain after slamming his fist on the table as he asked for another beer. On further history, you learn that he actually fell off a horse a while ago while he was riding towards the Shire, landing on a dorsiflexed wrist, but said nothing for fear of humiliation by his elf friend Legolas. So if anyone who doesn't watch Lord of the Rings, this is Gimli. You get some x-rays. What do you see? And this is a little harder, so I'll break it down by each view, and we'll talk about each view separately. But if anyone sees anything obvious standing out, you can shout it. Yeah. So, yep. Over here, like on the ulna. Yep. So the ulna fracture, lunate dislocation. Anything else? Something maybe in the pronation oblique view on top of the ulna. Okay, we'll go through it. All right, so like a lot of you guys pointed out, there is that obvious ulnar styloid fracture that arrowhead is pointing toward. And then a lot of people also pointed out the scapholunate dislocation. So normally, the spacing between each of the carpal joints is about 1 to 2 millimeters, and you see where that star asterisk is pointed, there's a widening of that region, and that happens when you get disruption of the scapholunate ligament, leading to what they call a Terry Thomas sign. And Terry Thomas was apparently a famous British comedian who had a huge gap between his incisor teeth. So next time you see that, you can let ortho know that there's a Terry Thomas sign. And then the other thing is that with a scapholunate ligament tear, it actually causes the scaphoid to rotate ventrally, so towards the palmar aspect, and it creates this ring sign right here. You see kind of like this ring that the arrow is pointing to, and that will also is an indication that there is that scapholunate dislocation if that Terry Thomas sign isn't obvious. And then on our lateral view, you'll see that it clarifies the reason for why we got that ring sign. This scaphoid, usually with normal axis of the wrist and the scaphoid, it creates a 30 to 60 degree angulation. But here, because that scaphoid has been dislocated and pushed towards the ventral aspect of the wrist, it creates almost a 90 degree angulation, which is what this image is trying to show right here. It does a better job than the actual radiograph. And then what a lot of people pointed out is that we did have that perilunate dislocation. So here, this arrowhead, you can see that the capitate is off center with the lunate. And so you can tell that it's the capitate that has gone haywire since the lunate maintains its articulation with the distal radius. So in figure A, that's what Gimli suffered, right? His capitate's off center while his lunate and radial distal radius maintained that articulation. If it was the lunate that was at fault, then we would see this image where this lunate would spill over and it would show that teacup sign that we see a lot in textbooks. So those are the two big findings on the lateral view, is that dorsal lunate dislocation, and then another view that the scaphoid has dislocated. And then lastly, this one was a little bit harder to see, was that there was a fracture in the triquetrum. Okay, so this, so to recap, Gimli was fortunate enough to sustain not one, but 4 injuries all at once. He had that ulnar styloid fracture, the scapholunate dislocation, the perilunate dislocation, and then the triquetrum fracture. And these fractures and injuries occur in a single pattern called the perilunate injury. So when you have patients that present to the ED and they tell you a story that they fell on an outstretched wrist and they landed like this to try to protect themselves. Consider that when you get that wrist radiograph, that you're going to look for more than just one sign, because these usually occur in unison. Okay. And then last one, very simple case, young male, notorious for punching things when he's upset, presents to the ED saying he punched the wall after finding out mom didn't pack Lunchables for lunch. This is his radiograph. What do you guys see? Yep, perfect. So people pointed out in the audience that there's a fracture right here in the 5th metatarsal, and this is the common boxer fracture that we see, which is a complete transverse fracture of the metaphysis of the 5th metatarsal, and it usually is without displacement. But in our case, it looks like there might be some displacement, and it looks potentially be ventral, but we should get a lateral view to get a better look at it in terms of the angulation. So summary, have a systematic approach as with most things in medicine. Know your terminology and practice with every x-ray you get. All right. Any questions?